Thank you. I thank you for inviting me here, and thank you for all the fascinating presentations. It was a very interesting day. And I mentally kind of thought about it in three ways, that we sort of started off the day looking at prospects for where we could go in terms of therapeutics for pain management in directions that were less reliant on opioids and had the potential of producing less harmful consequences than we've seen with opioids. And while there seemed to be some tantalizing lines of inquiry and potential pathways to developing new opioid or non-opioid therapeutics or therapeutics that act on things other than the opioid receptors, it seems clear that there's also a number of significant obstacles, and that it seems reasonable to think that at least for the next several years we are going to be living with opioids rather than having a substitute just around the corner that will do all of the good things that people associate with opioids and none of the bad things. And then we started to hear after that about what some of those harms actually were and what some of the downstream consequences are. And I think that's it's a bit of a lesson in it. This is what happens when we get it wrong. And that unpacking how we got here is an important part of the story of where we go next. But in the meantime, there's a lot of damage that's been done and a lot of damage left to undo or reverse if possible. And some of that continues to evolve, as we subsequently heard, in terms of the current dynamics of the overdose epidemic. I think that we heard some possible hopeful strategies for mitigating some of these effects more recently. But if there's one clear theme for me, it's that there's no magic bullets, right? And we cannot afford the luxury of magical thinking to think, oh, we finally hit upon this strategy, we just need to double down on it. I think for me it's interesting being in this particular workshop because I spend more time on the substance use side rather than the pain management side. And I often find when I'm at some other side of the table that there's some inherent tensions or some inherent need for translation or some inherent misunderstandings between the people who approach opioids from the point of view of substance use and the people who approach it from the point of view of chronic pain. And I think what's challenging is that I feel that at different points, people on both sides of that table have suggested strategies that the other side feels will have unintended consequences or push back against strategies that might be harmful if we try to take a balanced approach. And I think it's really important to hold on to the concept that people with chronic pain and people with substance use disorders, there's a considerable overlap between these populations, that you cannot just somehow partition off the substance use population from the rest of the chronic pain population and then say, okay, these are the patients for whom opioids are going to continue to be safe and appropriate. That those boundaries in that Venn diagram are fluid and they're fuzzy, and that in some ways that most challenging intersection of people with both chronic pain and substance use disorders, if we zeroed in on that and said, if we find some options that work for this subset, we'll find some options that might be meaningful for everyone, could be a productive direction to go. But I also want to say that kind of Venn diagram image, I want to complicate that because there's a kind of third term, and I think that we heard some of that this morning very clearly around mental health that's common to both conditions, both chronic pain and substance use disorder, and that maybe we should be triangulating a little bit more. But also more concern, I think we need to look at this in the context of socioeconomic status. I think there's a lot of promise and potential that has been underused and under-accessed and under-accessible in terms of physical therapy, complementary therapies, things like acupuncture, meditation. But I think about the people that Dr. Havens talked about, the people in more rural areas without access to these kinds of services or without insurance coverage that would support that, or who are working two jobs or have childcare responsibilities, or who simply don't have the transportation to make that feasible. And I think that's part of the picture of why opioids became so dominant in the management of pain for some populations, where that concept of patient self-management, there's so many intermediary barriers there to actually fulfilling that promise, especially the way that some of our healthcare delivery and financing is currently structured. But I wanted to I think I do a lot of policy work, and that's one of the directions I come at this from. So when we think of opioid policies, I think we've seen a number of different strategies, both discussed today and in the broader policy debate, that have implicit presumptions of what we really need to do is. What we really need to do is reduce opioid exposure. We should be much more wary of prescribing opioids in the first place, that we should use other pharmaceuticals, non-opioids, as first-line treatment and avoid opioids whenever possible. And that the hypothesis there being, if you get exposed to opioids and you are potentially susceptible to developing a substance use disorder, that this will send you down that path. Or alternatively, I think an implicit policy strategy is reducing opioid availability. So I lost track of the number of times that I've talked to lawmakers, members of Congress who, or heard them give talks where they say, yeah, I or my wife or my friend went to the doctor, went to the dentist, had some minor procedure done, walked out with a 30-day supply of opioids, when 3 to 5 or 10 would suffice. So this concept that opioid availability leads to a surplus of opioids that are then available for recreational use, misuse, diversion, that if we limit opioid availability, and I think that's where some of the PDMP recommendations come from, that looking at outliers in terms of prescribers, looking at doctor shopping, that will be the fix for us. And then looking at, what we really need to do is reduce the abuse potential, looking at reformulations, or what we really need to do is address misuse. Again, that kind of doctor shopping thing, or opioid contracts, urine drug screening, or what we really need to do is make the consequences of opioid misuse less harmful. So address naloxone, all of those things. And I think the challenge is that a lot of these policies get implemented sort of in isolation rather than in tandem. And that's where we get to some of the unintended consequences. What happens to those people who are flagged in a PDMP as so-called doctor shoppers? Well, from a lot of their doctors' point of views, that patient is now a problem for them. It's a problem for them on a sort of almost personal level. This patient has been lying to me. I feel betrayed. It's a problem on a potential legal or liability issue. If I keep prescribing to this patient, then is the medical board, the licensing board, the DEA going to come knocking on my door? And so what we hear anecdotally is that a lot of the patients that get flagged by PDMPs end up getting pushed out of healthcare. Where did they land? Are these the people that then transition to street markets for opioids, for heroin, potentially for fentanyl? We don't really know. And so if we imagined a situation where we look at the policy options in front of us, look at the potential issues around squeezing balloons and unintended consequences, and say, what do we need to do to implement and scale up in tandem, then I think that we would have less tension between our different attributions of causality of what we really need to do, and that different kind of push-pull of you're taking away my opioids at a time where we don't have enough access to treatment. Even if I were dependent, we don't have enough access to complementary and integrative care. If I wanted to be less reliant on opiates to manage my chronic pain, that we just don't have enough of anything. And that this scenario has been a pressure test on our broader healthcare system and public health system's ability to manage these challenges. So I think that, the other issue I wonder about is that we've seen some progress, depending on how you define progress, in some of the signals of potential harms of prescription opioids in terms of a plateauing or decrease in overdose deaths attributable to them, excluding the ones that are presumably illicitly manufactured fentanyl, reports of youth misuse of prescription opioids. At the same time as we've seen this increase in heroin and these indicators that prescription opioids may not be the primary transition point towards initiation of heroin. And so I personally worry that the dynamics of heroin use in the heroin market are starting to achieve almost escape velocity of velocity, to the extent that they've been sort of tethered to and risen in tandem and sort of on the back of prescription opioid misuse, if we have a new heroin market, a new heroin culture that's entrenched in a different way, then some of the legacy issues and some of the strategies that are prescription opioid-centric may actually not be enough to fully address this. I think that's where some of the things around medication-assisted treatment, especially buprenorphine, broader access to naloxone become especially important. But I'll stop there. I'm very interested in hearing what my other panelists want to say.